Good morning. I call this Health and Human Services Committee to order. We do have a quorum. We have a number of bills up before us today, members, so we will be as efficient as possible. Senator Champion, welcome to the committee. We will start with Senate File 1691.
Thank you, Madam Chair, and thank you to the committee. I realize that you have a number of bills today, so I'm going to try to be as expeditious as possible. Let me start by saying in your package should be some background information on this wonderful organization and all that they do. And so what I'll say is I'm honored to present Senate File number 1691, which appropriates $1 million in fiscal year 2026 to address disparities in maternal and child health outcomes within the African-American community. Studies show that culturally centered care models can improve health outcomes and reduce disparities, and systemic barriers to health care access result in considerably higher rates of maternal and infant health complications for African-American mothers. Research shows that culturally congruent care models can reduce these health disparities and improve outcomes. For an example, the maternal mortality rate for Black women in the United States saw a slight increase from 49.5% deaths per 100,000 live births in 2022 to 50.3 deaths per 100,000 live births in 2023. This figure remains slightly higher than the rates for whites, which is 14.5, Hispanics 12.4, on and on and on. These statistics highlight the critical need for targeted interventions, such as the African-American-focused Homeplace initiative to provide culturally centered care. That is what we're here for today. And a few of the benefits of the Homeplace initiative includes improved maternal and child health outcomes through culturally relevant care and increased access to prenatal and postpartum support for African-American families, data-driven recommendations for future expansion and continued funding, reduction in racial disparities in maternal health care, and the benefits go on and on and on. And so with me today is Pastor Howard, who is the Chief Operating Officer of Homeplace, to share more information about the program. And we do have a couple others who are here just to support, who are not testifying, but just want you to know that there are a lot of support here, including but not limited to Pastor Galloway. So thank you, Madam Chair, and my testifier is Ms. Howard.
Very good. Thank you so much. Welcome to the committee. Please introduce yourself and proceed.
Thank you so much. Hi, my name is Sarita Howard Odunigi, and I am the Chief Operating Officer for African-American Homeplace. And Homeplace is an oasis for families within Hennepin County where women, their babies, can overcome and receive non-medical wraparound support as an extension of the community. Women and their babies and partners will be able to receive access to care pre- and postpartum, such as acupuncture, massage, mental health services, financial education, parenting and birth preparation classes, CPR classes, and so much more. African-American Homeplace is a safe space for women and their families to meet outside of clinical settings, to meet with their birth workers, such as doulas, midwives, and lactation support, and whomever else is on their team. Within the, with the state's investment, our research shows through our current pilot program an immediate 2-to-1 return on investment. We are not only saving lives and reducing impact on health, but it is saving to your return on your investment. We are not only saving lives and reducing the impact on health, but it is saving the state within the same budget cycle to use healing methods to prevent medical crises. We will be doing and continue our analysis to determine additional savings as we help African-American birthing families start out in wholeness. The wraparound support we provide to support during and after pregnancy is the protective factor for their future and to save all babies. I am impacted by this because I joined this 2 months postpartum after giving birth to my son. And I had the opportunity to have this wraparound support, and it is not the testimony of many women in my family and community, so this is very deep for me. So thank you for your time.
Thank you for your testimony. Senator Champion, anything else before we move to discussion?
No, nothing else. Just we think that this is a great investment. It would also help families, and we believe that it should be resourced. So thank you, Madam Chair.
Questions, members? Senator Abler.
Well, thank you, Madam Chair, and I'm glad we're paying some attention to the, the birth justice and gestational justice along the way, where people, the outcomes are better. And, the problem with our fiscal note system is putting some money here actually might save $2 or $3 million down the line, and we do really never value the quality of life of the child and the mother and the family, which is in our fiscal notes not remarked upon. But this is the kind of thing that would make a difference, and even though it's like spending money, this is just a good place to put it. So I really appreciate you coming forward. Thank you.
Senator Utke.
Thank you, Madam Chair. And for Senator Champion, the bill is written, says it's for a grant to the Birth Justice Collaborative. That doesn't seem to show up anywhere, and I hear a lot of different names being used as you discuss how you would use the $1 million. Where would the grant go to, and does the bill need to be changed, because there doesn't seem to be a place for that appropriation?
Senator Champion.
Thank you, Madam Chair. Thank you, Senator Utke. It is for Homeplace, and we'll make sure that there's the clarity that you need. But it is something that has been with us, and even though Homeplace is in Hennepin County, that is the place where the resources would go and have historically gone.
Senator Utke.
Thank you, Madam Chair. That was it, just because there seemed to be a lack of clarity to the way the bill was written. So thank you.
All right, seeing no other questions, Senator Champion, any closing comments?
Closing comments is that I do believe that this is a way to improve the quality of life for birthing families. It makes a difference, as Senator Abler so eloquently articulated, and there are savings because you save lives, but you also help families go forward. So thank you so very much for the time.
Thank you very much. With that, Senate File 1691 will be laid over for possible inclusion in a future omnibus. And then Senator Champion will move to Senate File 2349. Go ahead.
Thank you, Madam Chair, and thank you to the committee. There is one amendment, Madam Chair, if someone could move that amendment, that would be great. It's the A1.
Thank you, Senator Champion. Senator Abler.
I'll move the amendment.
Senator Abler moves the A1 amendment. All those in favor say aye. Aye. All those opposed? Motion passes. Amendment is adopted. Senator Champion.
Well, thank you, Madam Chair. I thought I was going to have to say aye because the other members of the committee were still thinking about it. Let me just say. Madam Chair and members, thank you for letting me present this bill today. Most county-involved youth are able to get their mental health needs met within our current system. But there's a small population, however, has especially difficult needs, which we are not currently able to resolve. This committee is well aware of the need to improve our systems for county-involved youth with complex mental health and behavioral needs. A group of counties across the metro and the regional centers are working together to develop a regional plan to enhance and improve the response for their specific target population. By reimagining how we deliver services and building out strong partnerships across the counties, we are ensuring that care is determined by the need of the individual as opposed to the system they enter. This approach is being built out by a new Youth Services Coordinating Board made up of 7 counties who have come together to leverage their resources. Counties have asked me to support a metro regional approach to address systems issues preventing youth with complex health and behavioral needs from receiving services. So this is not a new concept and was one of the key recommendations of the working group of youth interventions. So in Minnesota, there's a note of lack of system capacity for youth with most of these complex needs, and so no one county can provide all the resources, supports, and interventions to effectively service this target population. And so youth with complex needs may be involved in multiple systems, including human services and youth justice systems, often moving between systems. This leads to delays in connecting youth with needed services and extended wait times for appropriate placement settings. So establishing this regional approach will allow counties to leverage their individual and collective strengths and capacities to create partnerships within the system. And with that being said, I do have one testifier that's with me. This is Commissioner Jeffrey Lundy, who's from the Hennepin County Board.
Mr. Lundy, welcome to the committee. Please introduce yourself and go ahead.
Thank you. Thank you, Chair and members of the committee. I'm Jeff Lundy, Hennepin County Commissioner for District 1, and also former chair of the Working Group on Youth Interventions. I'm here in support of Senate File 2349. I just want to thank you for the opportunity to testify today about the acute need for a comprehensive approach to providing care for county-involved youth with complex mental health and behavioral needs. Building off the recommendations of the Working Group on Youth Interventions, the Hennepin County Board passed a resolution last October directing our county administrator to convene a multi-county work group to work with community members, other stakeholders, and providers. The task of the work group was to develop a regional plan to address placement options for county-involved youth with complex needs in both human services and juvenile justice systems. The work group identified several legislative policy and funding proposals that would have both immediate and long-term impacts on maximizing capacity and better care for the young people who need it. Hennepin County made a commitment to address one of the most acute gaps in need, which is youth crisis stabilization. Hennepin County is funding and opening a youth crisis stabilization center at our behavioral health center. The new space will serve youth with complex mental health and behavioral needs close to their home and families, regardless of which system they enter. This program will consist of 13 beds for short stays of 30 to 45 days, with a target opening of late this summer this year. This bill is a result of counties coming together to identify legislative changes needed to provide youth in our care with appropriate placement and treatment options across the continuum. We respectfully ask for your support for Senate File 2349. Thank you.
Thank you for your testimony. Senator Champion?
Madam Chair and committee, I think it's been well established. Again, there's some information in your packet, but establishing this regional approach can have significant impact on the way care is provided for youth, and one county can't do it alone, and the policy provisions in this bill will also help move this work forward. So thank you, Madam Chair.
Thank you. Questions or comments, members? Senator Abler.
Not to monopolize the day. I think it's a nice idea to do this. I would have signed on, but it's full. And so just a couple comments. I do want to point out that at the top of the packet is a letter from Anoka County by new Administrator Jim Dickinson. First time I've seen his name in writing down here. So, hey, Jim. He should be amazing doing that. It's good to see the counties working together. And Mr. Lundy, welcome back. I haven't seen you for a while. Good neighbor just to the south. And so to the supporters of the bill and stuff, I'm not sure if you're aware, we're a little tight on money. The targets came out. This, I think the last one you could show would save money with the birth thing. You could actually be productive. This is important, but I have a feeling that it's going to cost something more than we have even to offer. And so just as you go forward, Senator Champion, and to the promoters, there's some language in here that it's just policy which could go forward. And I think if you're trying to create this legislative task force, I suggest you abandon that and go with a county-led task force, just of all of you, and drag in the same people you want, and that we don't have to, you can deal with per diems or not. Many people you'd bring here already get paid. If you want to bring in some public people, you can see if you want to try to pay their car fare or something or buy them lunch. But I think it's an important thing, and the needs for these kinds of facilities are there. I don't know. Maybe I just can ask a question, Mr. Lundy. So the money in the bill, would that pay for this place, or the county is planning to pay for it? They just want to get a license for it.
Mr. Lundy.
Madam Chair, Senator, the money would help alleviate costs. So the crisis center, the Hennepin County is fully funding that. There are some, as we put our pieces, kind of like a summer barbecue, we put all of our stuff on the table. We know we're missing some things. We need to make some things better. Anoka County has some things, Dakota County. And so that money would help alleviate, but certainly not pay for it all. It's really to help counties take care of that system.
Yeah.
Senator Abler.
Sure. You know, and I think the times are different. You know, we've been, you know, we'll talk about our budget here sometime. I think there's still an effort to draw down more federal money. And in the heading, it says seek federal funding. Seek away. Just last week, we just had a sudden cessation of money that there was a contract for, which was really infuriating to me that we would do that. And I wrote a letter and I called it morally indefensible to do that, and I think it is. But so I wouldn't count on the feds to give you much money, and if you didn't notice, we're short. Pick a number. Is it $2.5 billion? Is it $6 billion? It's a lot. But I think that it's a different time to find more collaboration, which I think that the 7 counties are doing, and I commend you for that. And if you, Senator Champion, if you want me to help you rewrite it so you can get something done here and move it forward. I think the licensure thing might be important. And anyway, so thank you very much. This is meant to be me trying to help, so thank you.
And
Senator Champion?
Madam Chair, we certainly, and Senator Abler, we are certainly always open because we believe it's important for us to work together and find ways to move both the policy, and if we can find some resources, that would be helpful. A well-known saying just says, we are better together. And so the counties are demonstrating that, and us working together is always for the betterment of our society and for all of our young people. So thank you, Senator Abler.
Senator Utke?
Thank you, Madam Chair. Where's this bill going next?
We're going to lay this bill over today.
Okay, because it did have stuff in there, and it looked like the amendment took out everything that would have needed it to go on. So, okay, that's what I was just confirming. Yeah. Thank you.
All right. Any closing comments, Senator Champion?
No, thank you so very much. Thank you for hearing it. I know you have a number of different things going on, but again, the best investment that we can make is to our young people, and we want them to get the services that they need so that they can continue to live quality-filled lives. So thank you, Madam Chair.
Thank you, Senator Champion. With that, Senate File 2349 will be laid over for possible inclusion in a future omnibus. All right, next we are going to move to Senate File 2109. Senator Pappas, welcome to the committee. When you are ready, please begin.
Thank you, Madam Chair. I'm inviting my testifiers to come and join me here. Good morning, everyone. I'm very pleased to present Senate File 2109, which seeks to increase the reimbursement rates for freestanding birth centers in Minnesota. With my co-author, Senator Abler, we authored the original birth center bill in 2010. Today, freestanding birth centers are particularly needed as the U.S. and Minnesota have a maternal health crisis causing high levels of maternal morbidity and mortality. We know there are stark racial disparities, and large areas of greater Minnesota can be considered maternity care deserts. According to a March of Dimes report conducted in 2023, about 19.5% of our Minnesota counties are considered maternity deserts based on the availability of facilities, maternity care providers, and percent of uninsured women, and the statistic is getting worse, not better. In addition, every year more and more Minnesotans choose birth center care. The problem. However, birth centers in Minnesota are struggling to sustain and grow due to inadequate reimbursements and payment models that do not align with the birth center model of care. 2 birth centers have closed down in Minnesota in the past year alone, mainly due to financial stress on their practice in response to unsustainable reimbursements, both from the state and private insurance payers. This bill would increase the birth center rates paid by medical assistants for the facility portion of newborn and birthing care, plus provide clarity to ensure that birth centers are compensated for the care they provide. Currently, the birth centers are paid a reduced facility rate that's inadequate, even by Medicaid standards, for their operational costs. This inadequate funding is contributing to closures and difficulty expanding into more communities. Birth center providers are also unable to bill for the full range of care they provide, such as labor support prior to a hospital transfer and required newborn screenings due to a mismatch between billing structures and their care model. This bill would allow DHS to work with the birth centers to resolve this, codify solutions to other mismatches that have already been resolved, and ensures the health plans also pay for this care, which is built into their existing capitated rate. These changes will better reflect the value that birth centers deliver to the state and to families while still providing savings to the state due to improved outcomes and lower intervention care. When birth centers are paid appropriately for their services, they're able to thrive and grow, allowing for more access to the best in-class model of care that every Minnesotan deserves to have as an option. It really is an option for families, And the research has shown that we do save money with birth centers because they have a very low rate of C-section and are more cost effective, but it doesn't mean that they should provide service to women and babies on the cheap. So I have with me Amy Johnson Grass, who is president of the Minnesota chapter of the American Association of Birth Centers.
Senator Pappas, I believe you have an author's amendment. Would you like to adopt that first?
Chair, I do have the A1 amendment.
Senator Abler moves the A1 author's amendment. All those in favor say aye. Aye. All those opposed? Motion carries. The amendment is adopted. All right, we will move to testimony. Ms. Johnson-Grass, please introduce yourself and proceed.
Chair Wickland, members of the committee, first I want to thank you for the opportunity to testify today. My name is Amy Johnson-Grass. I'm a midwife, and I'm also the owner of Twin Cities Birth Center on Grand Avenue in St. Paul, and the president of the Minnesota chapter of the American Association of Birth Centers. So I'm here today to represent all the birth centers in the state of Minnesota. I'm here to express my strong support for the passage of SF 2109, which aims to address and promote sustainable reimbursement for freestanding birth centers here in the state of Minnesota. To begin, I just want to clarify what a freestanding birth center is. In Minnesota, freestanding birth centers are independent facilities that provide comprehensive maternity care, including prenatal care, the labor and delivery, and all of the postpartum care. These centers are licensed by the Department of Health and nationally accredited by the Commission for the Accreditation of Birth Centers. The statute to license freestanding birth centers was passed in 2010, and all the providers working in these centers are licensed by their respective professional boards. The patients served are considered low risk, meaning they're healthy prior to pregnancy and during their pregnancy. About 80% of the population is considered low risk and appropriate for care in a freestanding birth center. Care typically begins around 10 weeks of pregnancy, and patients receive the same comprehensive maternity care as those in conventional maternity models, but they deliver their babies in the birth center instead of a hospital. Freestanding birth centers play a vital role in providing high-quality, patient-centered care, offering an alternative to the hospital setting for those seeking low-intervention birth experience. Research does show that freestanding birth centers exceed benchmarks in our value-based care systems. At birth centers, patients who receive prenatal care have 20 to 25% fewer C-sections than those who go to the hospital. Women who give birth in birth centers experience fewer maternal complications, such as hemorrhage or infection, and their newborns have fewer complications compared to those born in the hospital. Birth center babies have a 3% lower rate of NICU admissions. Birth centers also report higher breastfeeding rates and higher patient satisfaction. These outcomes result in healthcare cost savings, not because birth centers are paid less. It's because of our good outcomes that reduce the burden on the medical system. Despite the critical services that provide and the superb outcomes that are consistently delivered, these centers face significant challenges related to reimbursement from insurance providers, government programs, and other payers. Pegging birth center reimbursement rates to hospital rates has not worked and make it difficult for these centers to retain qualified staff, leading to higher turnover rates and potential shortages of trained professionals. Lower wages also affect overall staff morale and job satisfaction, and it further exacerbate the recruitment and retention challenges. By addressing reimbursement issues for freestanding birth centers, policymakers can help foster the growth and sustainability of these important community-based healthcare facilities, ultimately improving access to high-quality maternity care across the state of Minnesota for everyone. Thank you.
Thank you very much. And if you could please state your name for the record and begin your testimony.
Thank you, Madam Chair and members of the committee. I am Dr. Shekinah Fashaw-Walters. I live in Brooklyn Center, and thank you for the opportunity to testify in support of this bill. I gave birth to my first child in December, and the support I received at the birth center that I used made all the difference in my experience and well-being during and after my pregnancy. As a health services researcher, I know about the many poor maternal health outcomes that we've heard about today, and especially especially for Black women. So the importance of birthing in a place that I felt comfortable and that was also safe was incredibly important to me. I started my care with an OB, but I only felt like a number and really did not feel heard throughout my care. So at 27 weeks, I actually transferred to a birth center. Roots is the closest birth center to me, and also provides a welcoming environment for birthing people who look like me. My first appointment was an entire 90 minutes long with a midwife, and right away, my husband and myself, we felt comfortable and even more supported as we were starting on our journey of becoming parents. The support and confidence continued throughout my pregnancy, even though I ended up not delivering at the birth center. When I arrived at Roots, I was in labor and they could tell that the baby was in distress, and so I needed to be transferred to a hospital. And once I was transferred to that hospital, I would say the care from my midwife was even more important. During that time, my midwife made sure I understood everything that was happening at the hospital. She somehow slowed down time, even though we were in the middle of an emergency, to make sure that I felt comfortable, and she stayed with me until I came out of my emergency C-section. Had I not begun with Roots, I likely would have had to receive Pitocin at the hospital, which would have made my contractions come continuously and would not have allowed for my son's heart rate to come back up during those breaks from contractions. Without Roots support, I would have questioned if everything was done that could have been done, and now I have the confidence that everything was done well, and that I now have peace of mind that I am healthy and so is my baby. And I wish that everyone could receive the sort of care that I received at Roots. And I thank you all for all of your support in doing what you can to help birth centers.
Thank you very much. Members, do you have questions or comments about the bill? You go second. Okay. Anybody else? I think you have to go first.
Well, thank
Senator
you, Madam
Abler.
Chair. This is a really good piece of legislation. And it's too bad we actually need it. It just tells the health plans to pay the same prices. And we hear about mandates and like, oh, they're going to cost money. Actually, health plans, if you do this, you will save money. So please just do it. Madam Chair, I hope that as we mark up this bill, this should not actually cost anything, it seems to me. Except the complaining of the health plans that we are making them do one more thing that they should be doing all along. There's a study, I don't know if you saw this, Senator Pappas and others, from 2023. It compares birth centers with hospitals, and nothing against hospitals. But just so you know, the hospitals don't win the contest. And so this is over a 10-year period, involving 6 or 7 clinicians, some from the U of M, using birth centers compared to hospitals. Some of those were in Minnesota. And it says just what Senator Pappas was saying, that there's less C-sections, more burden, less NICU admissions, which is really expensive, health plans, and neonatal deaths, which we're kind of against those, and more breastfeeding. And what they don't mention is just the much more desirable alternative for the mother and family and the baby, which we've had testimony to. So it's time for this. If we really are trying to do a better job in this challenging moment, this is a way to do better and save money. And it simply requests that the plans pay the same price that medical assistance pays for whatever site people go to. And any of the people that went to these birth centers could have just as well gone to a hospital. And if we draw them out into these other places, there will be less complications. And this is, if you care about gestational justice and birth justice and equity, everybody should have a chance to have one of these opportunities. If you have means, you can go anywhere. If you don't, you're stuck with whatever comes along. And if there's no birth centers to go to, why should people be deprived of that just because they just didn't have the money? And this is a phenomenal bill, so I guess I like it. Thank you, Madam Chair.
Thank you. Any other questions or comments? Well, I don't see any other questions. I appreciate the presenters or your testifiers being able to help us understand the importance of this bill and being able to access birth centers and the great outcomes that you're seeing. Senator Pappas, any final comments?
Thank you, Madam Chair and members. Just a personal note. So I personally did not have hospital births and worked with a midwife, and my youngest daughter became a midwife, and her ambition is to start a birth center in Israel where they don't have birth centers. So it's very this kind of legislation is very close to my heart.
Thank you, and thanks for bringing the bill forward. Senate File 2109 as amended will be laid over for possible inclusion. Thank you. Next, we move to Senate File 1030. Senator Mann. Senator Mann.
Madam Chair, members, Senate File 1030 will establish a dementia coordinator at MDH. We all know someone whose life has been touched by dementia, parent, grandparent, a friend. The disease doesn't just impact the person diagnosed, but reshapes the lives of entire families. And those families are often left navigating a really confusing maze of services and supports with no clear path and no one to guide them. And our families deserve better than that. Especially with an aging population, we need to be proactive in how we get people the services that they need. With someone dedicated to do this work, we can get the people the services that they need, but we can also focus on preventing the development of Alzheimer's and other dementias, and slowing the progress of this disease, which will save the state millions down the line, but most importantly will make the quality of life for so many Minnesotans so much better. With that, Madam Chair, I have a testifier.
Thank you, and welcome to the committee, Mr. Freeman. And please state your name for the record and begin your testimony.
Good morning. Chair Wicklund, members of the committee. For the record, my name is Robert Freeman. I'm the Vice President of Public Policy for the Minnesota-North Dakota chapter of the Alzheimer's Association. Our mission is to lead the way to end Alzheimer's disease and all other dementias by accelerating global research, driving risk reduction and early detection, and maximizing quality care and support. Thank you so much today for the opportunity to testify in support of Senate File 1030, which would establish a Dementia Services Program at the Minnesota Department of Health. Alzheimer's disease and other forms of dementia are one of the most complex and expensive public health challenges we face today. As you can see from the handouts in the packets, more than 100,000 Minnesotans are currently living with dementia, and that number is growing rapidly. We're spending about $1 billion a year on this disease just in Minnesota, which will affect 1 in 10 seniors. A study in The Lancet in 2020 suggested up to a third of dementia cases are preventable, but today there's no single person within state government whose full-time job is to focus on reducing the incidence of dementia and coordinating services for those whose lives are currently impacted. This bill doesn't create a new program or new bureaucracy, it creates clarity and coordination. Right now, dementia-related work is scattered across multiple departments and agencies, often with little communication between them. The result is inefficiency, duplication of efforts, and missed opportunities to better serve families and caregivers. A dedicated dementia programs manager will help connect the dots. This position will have a line of sight into the various programs and funding streams that touch dementia, ensuring better coordination and smarter use of existing resources. Minnesota won't be alone in taking this step. 29 other states and Washington, D.C., red and blue, have already recognized the value of a point person on dementia. In other states, we've also seen these positions have been instrumental in leveraging federal and philanthropic dollars that can also help bolster communities' dementia services as well. We're behind, and this is a fiscally responsible step to catch up and make sure our public dollars are working as effectively as possible, but to provide the best services for our constituents whose lives are impacted by dementia. I also want to thank Senator Mann for her leadership in authoring this bipartisan legislation, as well as several other members of the committee. This bill is also supported by the long-term care associations, AARP, Catholic Charities, the Area Agencies on Aging, Elder Justice, Lutheran Social Services, the Minnesota Home Care Association, Volunteers of America, and numerous other organizations working to help elder Minnesotans. Please support Senate File 1030 and help improve dementia services for Minnesotans. Thank you.
Thank you very much. Members, do you have questions about the bill or comments? I don't see any questions coming up. Thank you, Senator Mann. I think that in my experience, I've heard about different things going on in the state, and I've wondered, is there a better way for us to kind of coordinate efforts? We could maybe expand efforts that are successful in a more efficient way if we had a way to coordinate them. So I think the program, establishing a program and someone to help coordinate all of the activities that are going on, it seems like a reasonable approach. So, Senator Mann, any final thoughts? Okay, Senate File 1030 will be laid over for possible inclusion. Thank you. Now we will move to Senate File 2371. Senator Dibble.
Thank you, Madam Chair.
Welcome to the committee, Senator Dibble.
Thank you, Madam Chair, for the opportunity to present Senate File 2371. Madam Chair, this is brought to you as some of the changes, one of several bills that are traveling into other places as well, prepared by the Office of Cannabis Management as we move towards rolling out the adult use market and also kind of wrapping in some of the considerations that we need to make for the existing and standing medical use market that we have already. Madam Chair, I'll just give a very high-level overview of the proposal. The general theme is to improve access and protections for medical cannabis patients. It's a series of minor changes to the medical cannabis program to improve access and protections to both patients and caregivers, adding consistency in definitions of allowed activities for caregivers and expand access for tribal medical patients under the new licensing framework to avoid disruptions in their current access to the medical program. So very quickly, a few of the items are that it clarifies an employee's role in distributing medical cannabis, so that they are consistent with the requirements outlined in Section 152.29. Updating these requirements assures access to the remote option for patients who are seeking consultation and allow for more cannabis businesses to participate in the medical program, especially in rural areas. Prevents discrimination for cannabis patients when it comes to housing, employment, educational opportunities, and other things. It aligns the existing statute with new policies implemented last session to clarify that caregivers may be designated to grow plants on their behalf and provides clear expectations around that particular service they provide. And then it maintains tribal reciprocity for medical patients to purchase medical products off tribal lands at state licensed medical dispensaries. So it would eliminate a disruption in access to the program as it prepares to transition to the new licensing framework. Madam Chair, we have Eric Taubel from the Office of Cannabis Management who can go into further detail.
Welcome to the committee, Mr. Taubel. Please state your name for the record and begin your testimony.
Thank you. My name is Eric Taubel. I'm the interim director of the Minnesota Office of Cannabis Management. Senator Dibble did a great job of laying out exactly what the proposals in this particular bill do. The key words are really about continuity to ensure that the existing medical programs, protections and opportunities move forward in the new Chapter 342 cannabis system. We have a couple of key fixes to language, notably, as Senator Dibble mentioned, language in 342 contemplates the ability to use a virtual consultation with a licensed pharmacist or cannabis consultant, but current language requires that that same person physically affix a label to the product at the point of sale. This incongruity functionally cuts off the opportunity for virtual consultation for patients, which is especially important for patients who live outside the metro. We also do bring over from the existing medical program, the Tribal Reciprocity Program, which allows tribal members who are enrolled in a medical cannabis program through their nation to participate in the stateside program. This is distinct from compacting and is already existing in the current program. And then finally, we add some protections to strengthen the protections in the existing medical patient registry program. The written testimony provided by the Mann organization highlights some of the ways in which these proposals will help actual people. Notably, they highlight the story of one healthcare professional who's a member of the registry and uses medical cannabis and has been subject to additional scrutiny or testing because of that choice to enroll in the medical cannabis program. The provisions also add a steeper fine for violations of those protections and gives patients the opportunity to use injunctive relief to stop or delay actions that would be illegal under the existing statute. Thank you.
Thank you. And then there's one testifier signed up on Zoom, Maren Schroeder. If you could please state your name for the record and begin your testimony.
Good morning, Chair Wicklund and members of the committee. My name is Maren Schroeder, and I'm here on behalf of the Minnesota Cannabis and Drug Policy Resource Center in support of SF 2371, specifically the updates to MnSTAT 34257 that strengthen patient protections. For nearly a decade, anti-discrimination language for medical cannabis patients has existed in statute, but in practice, it's been nearly impossible to enforce. During my time leading Sensible Minnesota's patient program, I worked with countless patients who lost jobs, housing, or access to services simply for being in the medical cannabis program. Yet very few were able to assert their rights because the cost and complexity of litigation made it out of reach. Section 8 of the bill begins to shift that burden. Instead of forcing patients into court just to understand why they've been denied housing, employment, or education, it requires landlords, schools, and employers to clearly articulate their rationale. That transparency is essential and long overdue. The bill gives real enforceable meaning to rights that have existed on paper for years, protections patients desperately need and deserve. I also want to voice support for Senator Curran's anticipated amendment to expand 34256, requiring healthcare facilities to accommodate hemp-derived and adult-use cannabis products used by registered patients as part of their care plan. Professionally, I've heard from several healthcare workers forced to deny patient access to these products, not because they didn't believe in the benefit, but because facility policy only reflects the bare minimum required under current law. Personally, I've lived this with my mom, who has MS, pancreatic cancer, and cognitive decline. She uses hemp-derived cannabinoid oils, some not even available through Minnesota's medical program. Over the last year, she's had 3 hospitalizations. The first 2 times, I fought for the hospital to allow her oils, which they did under a continuity of care exception. But during her most recent stay, the department pharmacist denied the exception and stopped the order without notice, stating, quote, per hospital policy, hemp-derived OTC cannabidiol products or non-Minnesota state licensed cannabidiol or medical cannabis products are not permitted. CBD order was discontinued per policy. Instead of her oils, they gave her a heavy antipsychotic that left her unable to wake for nearly 24 hours. We had to bring her home in a deeply sedated, confused state because the hospital refused to honor a care plan endorsed by her outpatient providers. These patient protections really do matter. Patients should not lose access to care that works for them simply because they enter a hospital or live in subsidized housing. I sincerely appreciate the committee's time and your consideration of these long overdue reforms.
Thank you very much. Members, do you have questions or comments about the bill? Senator Curran.
Thank you, Madam Chair. And as long as the testifier gave testimony to an amendment, we should probably introduce an amendment. So, Madam Chair, I'd like to introduce the A5 amendment to Senate File 2371.
Senator Curran moves the A5 amendment, and that is one that needs to be passed out to the committee. So, Senator Curran, if you want to start to present.
Sure. Thank you, Madam Chair. And Senator Dibble, as our testifier just stated, I think it falls in line of how do we look at where are those areas where we have gaps in kind of reviewing the medicinal cannabis program. I have great fears. I'm kind of fond of the medicinal cannabis program. I do think it provides great value. I served as the co-chair on that committee or the task force for a while, or the commission, whatever we called it. And so I think, and I'm concerned, I won't go into all the other areas where I think it's at great risk, especially around, people that need access to help with dosing to figure out, and then as well for minor children. But this amendment does cover, as Ms. Schroeder spoke of, in the healthcare facilities, that they have that right for medicinal cannabis or medicinal cannabis patients and those that qualify. It doesn't mean it overrides tobacco policies in a medical facility. It's not about smoking, but all other forms that if the person can administer it themselves and they have the capacity to do so, that they should not be prohibited. So that's what this amendment covers, and would appreciate everybody's support and consideration.
Senator Dibble.
Thank you, Madam Chair. While I believe this amendment has merit, and I have some passing familiarity with the issue, I hadn't known about this amendment coming forward until this moment, number one. The advocate, Maren Schroeder, who I'm friends with, has not sought me out for a conversation about this, nor let me know that this amendment was forthcoming. So I'm left a little bit flat-footed. I also notice we have Senator Hoffman here, of course, that this affects facilities that are within the jurisdiction of his committee. So I would be a little reluctant to be adding amendments that would cause another committee stop at this point. I would, again, I'm sympathetic to the proposal, but I would love some opportunity to discuss it in further detail and also check in with the stakeholders, as I do when we are dealing with long-term care settings, assisted living settings, and the like, to understand if they have any perspective on the matter.
Thank you. Senator Port.
Thank you, Madam Chair. Senator Curran, thank you for bringing this amendment. It's something we've been talking about and working on since the beginning of the legalization process. I am supportive of this idea. I think it is ensuring that patients have continuity of care when they need to be in a facility is really critical for their well-being. And so I am supportive of the amendment, but I also defer to, the author on process and sort of the time that is left, the ability to get this through the needed committees. But I am supportive of this policy change.
Thank you. Senator Boldon.
Thank you, Madam Chair. Thank you, Senator Dibble, and thank you, Senator Curran, for bringing this. I too will, defer to the author on process, but do hope the concept is considered as we move forward. Similar to the testifier, I have dealt with trying to get continuity of care in a hospitalized situation. So my son has significant health challenges, complexities, is on a medical cannabis regimen that works very well for him. And when he is hospitalized, it is always very difficult to be sure that he gets the medications that is his regular, regimen and routine that works for him. And so I just appreciate efforts to make that easier for patients, to be sure that we are doing what works for them. So thank you for this work.
Before I go to Senator Abler, I just wanted to make a comment that this bill is, from our committee, needs to go to the Judiciary Committee, and then this amendment would definitely require hearing in Human Services. So just wanted to put that information out, and it is Tuesday of deadline week. Senator Abler.
Well, thank you. Just Senator Curran, if you could answer me a question. What does this do for an abstinence-based sober home? Would they be required then to provide this? Right now, they do not do that.
Senator Curran.
Madam Chair and Senator Abler, I do not see that listed here from is that considered a medical facility? I guess I'd have to defer to somebody in council to make a determination on a sober home.
All right. So
Senator Abler.
and I don't know the answer to that, but it just says, I mean, the first one is they can set up policies, which who cares? But the second part is you can't say they can't use it. I know that the shelter that we run up in Anoka for the veterans is not licensed except by the county, so then we could deny that. But I just want to, that's this whole thing, I've given up trying to make this protect people from cannabis, but some people need to be protected from this, and that's why there's some restrictions. So I think Senator Hoffman has a thought. Thank you.
Senator Hoffman.
Thank you, Madam Chair. With that, I know that it's not considered a healthcare facility, so that 144A piece on it, but, you know, this lays in with where we were going, and it sounds like if you're good with this, if we're all good with this, I can waive it going to Human Services, because if it does not, I'm not seeing that it does affect the sober home. She's shaking her head, Ms. Hoffman. Do you want to, can I ask her, will you yield to my question there, Ms. Hoffman?
Ms. Hoffman, do you have a response?
Madam Chair, Senator Hoffman, members of the committee, sober homes, I believe, are not included in this list, and so then these requirements would not be required for sober homes.
Senator Abler, or, I'm sorry, Senator Hoffman.
Well, I think there's a proposal to license them at some point. When they get licensed, are they going to be under these chapters? That's just, Senator Mann, you're working on some of that, and just, so that's one question. And then what places are included in this? Is this nursing homes so grandma can sit there and eat her gummies and stuff? Is that what, I suppose that she should be allowed to do that, if that's the question. So maybe Senator Mann, do you know when?
Senator.
Should be much happier.
Senator Mann.
Madam Chair, we would really
Senator
appreciate
Hoffman.
Senator Mann's opinion on grandma and gummies.
Madam Chair.
Senator Dibble, yes.
So let me just say this. I sense support. I, of course, am somewhat familiar with this. And, of course, we do have another stop in judiciary, so there will be time to have some more conversation between now and Friday. So I'm willing to accept the A5 amendment, but I also want to communicate something quite clearly. I'm good friends with Senator Curran. I'm good friends with Mayor Schroeder. My door is always open. This bill has been sitting out there for quite a bit of time. Anyone has, and many have, come to see me with their ideas for medical cannabis tweaks and policy changes and ideas, as well as, I guess I've become the adult use guy now too. Didn't want to be, but here I am. And so please, just give me a call. Let's have a visit, a cup of coffee, talk about the ideas. Let me know what amendments you have in mind so that I can know about them and not learn about them when I'm sitting here at the table providing testimony. I'm trying to, be very supportive of everyone who has ideas as we go along to adjustments and tweaks and modifications as we figure out and learn things as we go along.
Madam Chair.
Senator Cran.
Thank you, and Senator Dibble. And so I was unaware that these amendments were prepared until last night, and they were prepared in anticipation when you were in Commerce, I believe, and unfortunately, whoever planned to do it wasn't there for that day or to introduce them. So appreciate it. I saw you run by, and I was going to run out and catch you, but then you disappeared earlier. But we would appreciate the consideration. I mean, if we don't do it here, there's ample time. We know any time throughout this entire process, anything can and will be changed. But I think it does meet one of those gaps, and it meets a gap in the intended modification or the intent of this entire bill as it is today. So, Mr. and Madam Chair, so I would encourage a yes vote. Thank you.
Madam Chair.
Senator Abler.
I think part of the problem with amendments on the fly is you just don't know what it's going to do. And so whatever the future of this after judiciary is something. But I think it would be prudent, at least for Senator Hoffman or his staff just to check with the sober home operators to make sure that they're not going to be caught by this. And if you read the language, it says so if they ever do get a license, they would come under this. Any old sort of license at all at DHS. Up on, it says that on line 1.8, other healthcare facilities, and I have to think that a sober home would qualify in someone's idea as a healthcare facility, or they'd be suing, the person desiring of using this would decide they're going to sue their facility. And the language on 124 is unreasonably limit. Sober homes, I don't know why I'm on that jag today, but there are some places that we talk about harm reduction and so on, and some places absolutely want to be abstinent because their guests there are incapable of fighting temptation, and it's going to trigger them, and they're going to get back off the wagon. So I know that Senator Dibble doesn't want that, and Senator Hoffman doesn't want that. So as this thing moves forward, I hope that can be taken into consideration. So thank you.
Any other comments to the amendment? I guess we will move to a vote on the amendment, and I certainly agree that, more time to discuss would help us understand some of these things before it gets to us. It does seem like it is addressing a concern. I think, we'll take a vote on it, and hopefully you can continue to work with Senator Cran and any other, if something comes up that doesn't seem like it's going to work correctly or impact others that we haven't anticipated. So, members, all those in favor of the A5 amendment, please signify by saying aye. Aye. Any opposed? The motion does prevail. The A5 amendment is adopted. Members, Senator Cran?
Thank you, Madam Chair. And Senator Abler and everybody, I share the same concern, especially around the sober home. So, as they move forward in licensing, I would certainly expect that we would carve those areas out if there's an abstinence program specific to the health. I get 2 kids drug and alcohol addicted. We share that common belief. And so with that, Senator Dibble, I'm sure you will enjoy the A6 amendment that I'd like to introduce.
All right. Bring it on.
I'd like to move the A6 amendment to Senate File 2371.
Senator Cran moves the A6 amendment, and that will be passed out to the committee. Senator Cran.
Thank you, Madam Chair. And Senator Dibble, what this amendment does is covers non-resident medicinal cannabis users and their children, or the ability for parents to acquire only from a registered or from a legal medicinal cannabis provider in Minnesota while on vacation or temporary residency in Minnesota. So that's what it does, and it again came through the same process last night as notified, and so that's what this does, and so we'd love everyone's consideration for it. Again, I think those are. It kind of follows the same path. On the medicinal side, I think we need to preserve it so they can get the medical care, the dosing, and the assistance, whether they're in state or out of state, especially for minor children, that they would have access. And yes, we would hope they plan better if they're taking a vacation to Minnesota. But that's what this does. So we would certainly appreciate your consideration. Thank you.
Senator Dibble.
Thank you, Madam Chair. Unbeknownst to Senator Cran, I actually have had some conversations about this idea and was working on it on a different track. So, I think this is an amendment that I would encourage a yes vote for. Just to elaborate a little bit, what this is not is, because I think this has come up in conversation in a slightly different context, and that is, at one time it was contemplated that the states with medical programs would create a kind of a reciprocity kind of agreement or compact or something like that, state to state, which never really transpired for a lot of complicated and good reasons. This is different than that, which is similar to how the medical program would operate vis-a-vis folks with a tribal medical patient identifier going to a state dispensary Similarly, someone with an out-of-state medical patient identifier could come to a in-state Minnesota registry. It doesn't work in the opposite direction necessarily. We're silent on that. But as someone who can't transport their medicine with them across state lines because of federal restrictions, and we don't want them to, be in violation of federal laws, needs to come here for a visit or a period of time. We want them to be able to access their medicine here. So I think this is a good amendment. Thank you, Senator Curran.
Members, any questions or comments about the amendment? Senator Abler.
Well, Madam Chair, if the last one was keep grandma happy, this is the smoke 'em if you got 'em, I guess. So, thank you.
Senator, I see no other discussion on the amendment. Senator Curran moves the A6 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The A6 amendment is adopted. Members, any other questions or discussion? Senator Hoffman.
Well, those actions, Madam Chair, just the whole bill's going to have to come to Human Services. I think we'll have to, we will have a conversation about that this afternoon. Thank you. Thank you for your work.
Any other comments, questions? Seeing none, Senator Dibble, any final thoughts?
No, Madam Chair, I appreciate the opportunity, the good discussion, the very fine amendments brought by Senator Curran, and appreciate the committee's time and support.
Thank you. So the motion is that Senator Curran moves that Senate File 2371 as amended be recommended to pass and be referred to the Committee on Judiciary. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and Senate File 2371 as amended is passed and referred to the Committee on Judiciary.
Thank you, Madam Chair and members.
Thank you. Next on our agenda, we will move to Senate File 2670. Senator Maye Quade. Welcome to the committee, and please proceed with your bill. I do see that, is there an author's amendment?
Yes, Madam Chair, there's the A1.
Senator Abler. Senator Abler moves the A1 amendment. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The A1 amendment is adopted. Senator Maye Quade.
Thank you, Madam Chair and members. Thanks for hearing Senate File 2670. This seeks to expand access to home-based phototherapy treatment for newborn jaundice. Newborn jaundice affects 60 to 80% of all infants, and 2 to 6% require treatment, including my daughter. Phototherapy, the standard treatment for jaundice, is safe and effective at home with proper medical support. The problem this bill is trying to solve is that currently there is a lack of home medical equipment providers who offer phototherapy services because there is such a low reimbursement rate that does not come close to covering the cost of providing these services, causing many newborns to have to be readmitted to the hospital to receive this treatment. This creates unnecessary medical costs and stress for families. Without access to home-based care, families face hospital stays averaging 3 nights at a cost of about $10,000. This bill seeks a reimbursement rate for home-based treatment at about $750 per infant. And members, this is a huge savings. I'll give you some back of the napkin math. There were 61,000 live births in Minnesota in 2023. Just on the lowest end of that range for jaundice at 2%, that's a minimum of 1,200 babies that would need phototherapy treatment every year in Minnesota. At $10,000 per course of treatment in a hospital, that number would be $12 million on the low end and $37 million on the high end if the service was only available in hospitals. At the proposed home-based rate, that is $900,000 on the low end and $2.7 million on the high end. We know that there is a mix of commercial and medical assistance in these numbers, so we don't know a true savings estimate today, but this is something that I hope the department could find savings for in a fiscal note. I actually don't think we would be doing dynamic scoring here. I think we would be doing just cost and savings. Providing this treatment at home will not only reduce costs in our healthcare system, but enhance parent-baby bonding and breastfeeding, reduce stress for parents, and free up hospital beds, and mitigate the risks of complications and infections. This bill offers a smarter, more family-centric approach that improves outcomes for infants, supports families, and reduces costs. And it's better for families, but it's also cheaper for the state, which should make this a no-brainer. So I'm really hoping we can pass this, and I have 2 testifiers with me, Madam Chair.
Thank you. Welcome to the committee, and if you could please state your name for the record and begin your testimony.
Thank you. Good morning, Madam Chair and members of the committee. My name is Cameo Zender, and I'm with Pediatric Home Service, and testifying to request your support for Senate File 2670. As Senator Maye Quade describes, this bill will increase access to phototherapy services in the home environment where it can be provided safely, effectively, and at a fraction of the cost of that similar treatment in the hospital setting. My co-testifier, Dr. Chawla, will testify that clinics and hospitals are challenged to find a home medical equipment provider that offers this service, and the reason is straightforward. Home care providers simply can't afford to fulfill the totality of the equipment costs along with the service requirements at the current reimbursement rate of $76.55 per day, or on average during that 3-day treatment period at a rate of $230 per care episode. And when home-based treatment is not available, these babies are receiving that therapy in the hospital setting. This bill establishes a 2-code rate methodology to supplement the current reimbursement. The second code proposes to reimburse at $520 per care episode, which accounts for the additional service requirements that go beyond the basic acquisition and replacement costs of the equipment. Using the average 3-day treatment period, the proposed episode rate under the 2-code methodology is $750, which is about 10% the average cost of hospitalization. You may be wondering why not just increase the daily rate and avoid the hassle of a 2-code methodology, and the explanation requires a brief history lesson. Under 2018 federal law, states can only claim federal matching funds of certain medical equipment, including phototherapy equipment, up to the amount that would be paid if the equipment was reimbursed according to the Medicare fee schedule. If the state were to pay more than the Medicare fee schedule, then it must use state funds to make up that difference. However, the second service code that's introduced here is not limited by that federal funding cap, and so allows the state to establish a sustainable reimbursement rate to increase access to home-based treatment, saving thousands of dollars for every infant treated, while ensuring we're maximizing the federal matching funds available. I ask for your support for this bill, and am happy to take any questions that you may have.
Thank you, Dr. Chawla. Please state your name for the record and begin your testimony.
Chair and committee members, my name is Dr. Gigi Chawla, and I'm the Chief of General Pediatrics at Children's Minnesota. Thank you for having me here today to express our support for Senate File 2670, which would establish a sustainable rate for medical assistance coverage for home-based phototherapy services and equipment. Children's Minnesota is the state's largest pediatric health care system, and nearly 50% of the services we provide are to families that rely on Medicaid. In partnership with the Children's Health Network, we care for more than 7,000 newborns each year. Roughly 80% of newborns present with elevated bilirubin levels, which causes skin and the whites of the eyes to look yellow, a condition that we typically refer to as jaundice. In most cases, this condition is not severe, and the symptoms resolve naturally. But for some newborns, treatment is required to avoid serious complications that could lead to brain damage, intellectual disabilities, or issues with hearing or vision. Phototherapy is the most common form of treatment for jaundice. Involves exposing a baby's skin to a specific wavelength of light for typically 2 to 5 days. It is possible for newborns to receive this treatment at home, with studies showing that home-based phototherapy treatment is just as effective as inpatient treatment when families have the proper equipment and clinical support. We are proud to offer home-based phototherapy treatment for patients and families as part of our home care program, because we know that it can improve outcomes for infants by supporting parents' abilities to continuously care for and interact with their child, enhance bonding, and support opportunities for breastfeeding. Unfortunately, providing this service is proving to be more difficult because of the costs associated with accessing home phototherapy equipment. If families can't access care at home, then their child must be admitted to the hospital, which is less convenient for the family and ultimately more expensive. An inpatient stay for this treatment is more than 10 times the cost of home care. Requiring medical assistance to cover this service at a sustainable rate is critical to our ability to continue to offer this home-based option to our patients. Thank you, Senator Maye Quade, for your leadership and for this important bill, and thank you, committee members, for your time today.
Thank you. I was just wondering, Senator Maye Quade, if you could say a little bit more, or maybe Ms. Zender, about the reason for the amendment. It looked like the phototherapy lights were included in one paragraph, and did that just not provide the adequate reimbursement to the costs? Or if you could elaborate a little bit more about the reason for the paragraph that we added. Ms. Zender, or Ms. Maye Quade?
Yes, Senator Wickland, a very good question. And the reason for the amendment is it proposes that two-code methodology. And we worked on this in collaboration with the department. If we were not to introduce that second code, any increase in the reimbursement rate would not qualify for additional federal matching funds, and so therefore would need to be reimbursed with additional state funds.
Okay, thank you. That's helpful to understand it better. Members, do you have questions or comments about the bill? Senator Boldon.
Thank you, Madam Chair. Very briefly, thank you, Senator Maye Quade, for bringing that. Anytime that we could allow patients and families to receive care at home, which is easier for all of their lives, but also, there's risks with being hospitalized, and there's definitely increased costs with being hospitalized. And so anytime we can allow that care to happen at home, we should do that. So thank you.
Any other comments or questions? Senator Abler.
Well, thanks. I don't know how deep we want to go into this, but this just seems like it's begging to be at least a zero-cost fiscal note, if not a savings. And I wish we had more time, but if we had a little more time, I'd ask the department to come and put their rationale together about how they intend to look at this. It's a relatively finite number of infants who need this, and it's just an obvious thing to me. If it's $10,000 and $750 a day comparatively, and so this is a good chance to show that there's a sensible approach to math at the department. And Madam Chair, if they ascribe a cost, we should put this in the bill anyway, and then dare them to prove in the forecast that it actually costs money, because this is just so sensible. And not to mention, again, the quality of life of the family has to drag their kid to the hospital, and there's no beds anyway, no pediatric beds in Coon Rapids anymore because Alina closed them. Should I bring that up again a few more times? But anyway, and there's just no beds, and people that want to serve them at home. So Senator Maye Quade and to the testifiers, this is a fabulous idea. So thank you.
Thank you. Any other questions or comments? Senator Maye Quade, it does seem, looking at the costs, it seems like having access to this would be beneficial for the families and certainly beneficial for us. We'll definitely look at the fiscal note and discuss more. Do you have any final comments?
Thank you, Madam Chair. And, I might be one of the first people to bring a bill to your committee that's going to help you save money and maybe spend money in other places. So happy to do that. I'll just share briefly. This was my family. My daughter was born with jaundice. I was discharged before she was, and we were in the hospital, and she was under the little phototherapy thing, but we had to hold her little hands. So we'd be standing there for 15 hours, each of us she would hold a finger. And then we finally rented a billy blanket and brought it home, and we were able to be at home and finally see family because we were her two visitors. We couldn't have my parents come. And so it really was like a game changer to not be in the hospital anymore for something we could do at home. We had to pay out of pocket, but that's not possible for everybody. And this is going to be a game changer for a lot of folks. So I'm really happy to bring this bill, and I'm grateful that I was asked to carry it.
Thank you. So Senate File 2670 as amended will be laid over for possible inclusion. And next we'll move to Senate File 1162, Senator Xiong. welcome to the committee, Senator Xiong, and please go ahead and present your bill.
Oh, hello. Thank you, Chair and committee members. I have before you Senate File 1162. It is a request to continue funding the Homeless Elders Program at Catholic Charities Twin Cities, the fastest growing homeless population in the state of Minnesota. And this group has the hardest time with the physical challenges of homelessness as well as the emotional toll. Older adults experiencing homelessness face complex challenges. Most have chronic health conditions. 90% are unable to work or complete some activities of daily living due to the natural physical decline of aging. Catholic Charities' unique homeless elders program provides essential services to those with the most acute needs. Connection to supportive programs like medical assistance and waivers, placement in affordable and stable housing. The bill before you today is written for $3 million in the biennium in 2023. Appropriation was $1.5 million per biennium. Reauthorization of $1.5 would maintain current service levels. The $1.5 million appropriation was used to scale the Homeless Elders Program to meet the rising needs of Minnesota's seniors. Wait times for services have been reduced for over 3 months to less than 30 days. Housing placements have been doubled, helping more than 300 seniors move in the past 2 years. After scaling up the program, Catholic Charities Homeless Elders Program team can serve approximately 300 individuals per year. In 2024, about 70% of Homeless Elders Program clients were successfully housed. At a time with so much uncertainty about public funding, if we at the legislature do not reauthorize the appropriation for the program, Catholic Charities would likely need to reduce the size and the scope of the work. And so with me, I have a couple of testifiers here with me, Chair.
Thank you. I have Mr. Kozarski and Mr. Thompson. Whoever would like to go first, please state your name for the record and begin your testimony.
Yeah, thank you, Madam Chair and members of the committee. My name is Bill Thompson. I was a homeless elders under the services. I was born and raised in Boldon, Minnesota, and my family taught me how important it was for the community. My career brought me to the Twin Cities, where I worked for many years as a restaurant consultant, helping open the fast food franchises. In my spare time, I volunteered regularly supporting people experiencing homelessness at Catholic Charities Dorothy Day Center in downtown St. Paul. I also served on the board of Westside Community Health Services, now known as Minnesota Community Care, for several years. In 2019, my life took an unexpected turn when my apartment flooded. Suddenly forced me and along with my neighbors to evacuate. And at that time, my finances were quite tight, and I couldn't find anything else affordable for myself to do. In an instant, I found myself facing homelessness. Although I never imagined this would happen to me, I knew exactly what to turn to. Catholic Charities, I found a safe place to sleep, eat hot meals, and the ability to meet all my basic needs. I figured with my experience navigating systems, I would probably figure out the next steps on my own. But let me tell you that after months in the shelter, I was really struggling. I realized that I needed help. That's when I found the Homeless Elders Program and met Danny. Danny's my case manager. She's been working with the homeless elders experiencing, elders experiencing homelessness for quite some time. She's an expert. She took the time to understand my situation, became my friend. Danny saw me. She helped me figure out that I was eligible for some supportive programs, and then did everything to help me with the affordable apartment. Transitions are difficult the older you get. Change is not easy, but the Homeless Elders Program is just fantastic. Tell them what you need and they'll help you. I'm proud to speak today on behalf of other seniors who are experiencing homelessness in our state. Aging is something we all have in common, and this can happen to anybody. I respectfully urge you to support Catholic Charities Homeless Elders Program so that others in our community can recover from hard times and rebuild their lives. Thank you for your time.
Thank you. Mr. Kozerski.
Good morning, Chair Wickland and members of the committee. My name is Keith Kozerski, and I'm the Chief Program Officer at Catholic Charities of the Twin Cities. Beginning nearly 2 decades ago, Catholic Charities noticed more seniors entering our shelters. These older adults frequently rely on walkers or wheelchairs. They struggle with memory loss and complex health conditions. Some are on dialysis, others being treated for cancer. Some are veterans, all are at risk of premature death. We've learned that many people experiencing homelessness at age 60 or older are in this position for the first time in their lives. They don't know how to navigate Minnesota's homelessness systems, leaving them especially vulnerable in our shelters. Catholic Charities met this community need by establishing the Homeless Elders Program, leveraging our expertise with Minnesota's Aging and Disability Services to help these seniors move into safe, stable homes as quickly as possible. Our staff provide intensive case management, assess benefit eligibility, and complete applications for health insurance waivers and assistance programs. We identify housing options, navigate coordinated entry systems, connect with healthcare providers, and more. The timely support the Homeless Elders Program provides can mean the difference between life and death. And in 2023, with your support, it helped us scale this program to address the rising number of seniors becoming homeless each year. Wait times for services have been reduced from more than 3 months to less than 30 days. And we have doubled the number of successful housing placements, helping more than 300 older adults find their way home. People like Mark Peterson, after a life spent working in manual labor, he couldn't afford the rent after his partner passed away. Mark found himself living in his car in a Cub Foods parking lot at the age of 69. A homeless elders case manager helped him access Social Security benefits and find an apartment. Today, he enjoys simple things like cooking his own meals and showering whenever he pleases. People like Thomas and Yolanda Norman, they lost their home when it was damaged by a storm. Yolanda is nearly blind, and at age 61, Thomas's kidney disease, COPD, and arthritis meant that he couldn't just return to his former work as a security guard. They spent nights sleeping in a local park, but after homeless elders case managers helped them enroll in Medicaid and apply for a subsidized apartment, they can now get a safe night's sleep in their own bed. All Minnesota seniors should be able to age with dignity. Statewide data shows that older adults remain the fastest growing segment of our homeless population. Reauthorized funding for Catholic Charities Homeless Elders Program will ensure that those in crisis will receive the life-saving support they both need and deserve. Thank you for your consideration.
Thank you very much. Members, do you have questions or comments about the bill? Senator Boldon.
Thank you, Madam Chair. Thank you, Senator Xiong, for bringing this bill. And thank you to the testifiers for being here, for sharing your story, and for sharing the stories of Minnesotans, because this is about people. And this is what we should be doing. As you said, all Minnesotans, everyone deserves to age with dignity. Everyone deserves a safe, secure place to call home. The luxuries of being able to take a shower whenever they want, or being able to, sleep in your own bed at night is something that everyone should have. And it's worth mentioning that seniors are the fastest growing segment experiencing homelessness right now. And given the challenges perhaps ahead of, we're seeing with Medicaid and Social Security, I fear that this is only going to get worse and affect more people. And so thank you for this work. This is absolutely something we should support.
Thank you. Any other member questions or comments? I'm not seeing any. I know in 2023, when we looked across the kind of the landscape of what was needed in the area of addressing homelessness, that this program seemed to fill a need that wasn't being addressed, and it's great to hear about the work that's gone on in the last year and a half to use the funding that we provided, plus, other funding. And it does seem to be a continuing need and possibly a growing need. So I really appreciate your bringing the bill, Senator Xiong, and we will consider it. We have a different financial outlook this year than we did at that time, but it is a really strong proposal. So thank you for coming. And then Senate File 1162 is laid over for possible inclusion.
Thank you.
Thanks. Next, we'll move to Senator Boldon. First, I think you want to take up Senate File 1538. Senator Boldon.
Thank you, Madam Chair. I do have an author's amendment. It is the A2 amendment, which just narrows the scope of the bill to reduce cost and prioritize our efforts in the area of greatest need, which is data collection.
Senator Boldon moves the A2 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The A2 amendment is adopted. Senator Boldon.
Thank you, Madam Chair. Senate File 1538 was brought to me by the Epilepsy Foundation of Minnesota, who shared that there are no dedicated state resources at the Minnesota Department of Health to support people living with epilepsy. This is all despite the prevalence of epilepsy. 1 in 10 people will have a seizure in their lifetime, and 1 in 26 will be diagnosed with epilepsy. Epilepsy is the most common neurological disease among children and a leading neurological condition among adults. Epilepsy is more than just seizures, as it impacts all aspects of an individual's life and their families. People living with epilepsy can experience poor health outcomes and low quality of life due to limited access to specialized care and resources. They experience stigma and isolation due to discrimination in schools, workplaces, and communities. This is because epilepsy is still widely misunderstood as a society. Additionally, direct and indirect costs associated with epilepsy significantly impact individuals and families financially. So this bill, as amended, would provide our state with critical public health information on epilepsy. It would ensure organizations like the Epilepsy Foundation of Minnesota, the only organization who directly supports this population, and the legislature, data to inform efforts to support Minnesotans living with epilepsy and their families. And so, Madam Chair, I do have a testifier from the Epilepsy Foundation to provide more background on the work that they do for our state and the need for this bill.
Welcome to the committee, and please state your name for the record and begin your testimony.
Thank you, Chair Wickland and committee members. My name is Angela Bennett. In 1954, EFMN empowers Minnesotans impacted by epilepsy and seizures through support, connection, education, and advocacy so that no one faces epilepsy alone. I'm here today to express our enthusiastic support for Senate File 1538 as amended. This bill would provide resources to the Minnesota Department of Health to collect data on epilepsy in our state. Currently, there are no dedicated resources within our state's public health agency to support people living with epilepsy or to understand its true impact on Minnesotans. Gathering this data would support EFMN in our own resource allocation and guide the legislature in policy decisions to ensure needs are being met in the most effective and efficient manner to improve health outcomes for Minnesotans living with epilepsy. We see our organization as a resource to the state as we support Minnesotans living with epilepsy, their families, and their communities. Our organization provides services such as seizure smart trainings in schools, child care centers, workplaces, to healthcare professionals like first responders or community groups. We provide one-to-one support for all people affected by epilepsy, whether directly or tangentially. From diagnosis through treatment, we help people by providing epilepsy information regarding care, medication side effects, transportation resources, programs, and more. Currently, the only information EFMN has about epilepsy in our state is that there are an estimated 55,000 Minnesotans living with epilepsy. We are a small but mighty nonprofit organization that seeks to support these individuals and their families. We firmly believe that partnering with the state to collect data on the number of diagnoses, clinical outcomes, mortality rates, and other related health data can support EFMN in targeting areas of need more effectively. This is just a starting point to where we hope to be in terms of how we support Minnesotans with epilepsy, and we're very motivated to make the most of the Department of Health's partnership. Thank you to Senator Boldon for carrying this bill, and a special shout out to Senator Abler for your many years of support. Thank you to all committee members for your dedication to bettering the health of all Minnesotans, and thank you for the opportunity to testify today.
Thank you very much. Members, do you have any questions or comments? Senator Abler.
Well, thank you, and thanks for the work of the Epilepsy Foundation. And most people know we lost a son 11 years ago, I guess it is now, to a seizure. Just to the bill, and I appreciate all you're trying to do. Actually, I think the original version would get more done in terms of some action steps, and it's your bill to work on it. But I think that if you ever get the money to do this, this is really vague, and like there was much more specifics here about actually trying to make a difference and helping people understand. And just from our point of view, we didn't lack money. We had good care. And he just had a checkup in August. Everything's fine. He was taking Tegretol, made him tired. And then he had a seizure in September. And so, you know, I don't know how, there's no way to have changed our thing. We can argue about why it came out in the first place, which is far beyond the scope here. But so where are the people who aren't getting any care whatsoever? Is it the Medicaid population? Is it people who have commercial insurance that don't know better? Just that kind of stuff I think would be interesting. And there's, you know, a lot of things that can be done, but I just wish you well in the process here. I appreciate your intent. But at the end, if in these lean times, if you get the money, I think you want to really make sure that it's going to be something that when the dust settles, that will actually advance something more than just having more data. So anyway, thank you.
Senator Boldon, did you?
Thank you, Madam Chair. Thank you, Senator Abler, for those comments and for sharing your story. I agree with you. I would like to be able to do the whole bill. There is a lot of work to be done in this area, in this space. We are trying to be as realistic as possible and sort of target efforts to get sort of the most we can with the resources as a start of this work.
Thank you. Any other comments, questions? Well, thank you for bringing it forward, Senator Boldon. I do think it is a need, and it's surprising to me that we don't have anything really set up to deal to address this, given the impact on Minnesotans and the number of Minnesotans. I think it is something that people could benefit in a number of ways, higher quality of life alone. Just, I know that from personal experience that finding the right medication is challenging, and there are a lot of different challenges. And if people could benefit from, pooled knowledge of different possibilities, it seems like that would be in itself would be a nice addition for us in the state. So, but Senate File 1538, as amended, will be laid over for possible inclusion. And next, Senator Boldon, you have Senate File 831.
I do. Thank you, Madam Chair. Appreciate being before you with this bill. This is a bill that would provide legislative funds for a Treat Yourself First program, an initiative to address burnout and increased rates of mental health concerns for healthcare workers. And I want to give you just a little bit of data and background about really the rates of burnout among healthcare workers that have reached a crisis level. Results from a survey among nurses indicate that almost 2/3 of nurses, 62%, experience burnout. I would argue that it's actually higher than that. A 2023 ADA Council on Communications trend report found that 40% of dentists felt defeated and wanted to quit dentistry. 74.9% of community pharmacists have experienced symptoms of burnout. Almost half of surveyed physician associates report experiencing increased symptoms of burnout or report being completely burned out. 48.2% of physicians reported experiencing at least one symptom of burnout in 2023, and 20% of physicians say they are depressed, but only 15% of physicians have sought out professional help, largely due to the stigma around healthcare workers seeking out mental health care treatment. Not only are healthcare workers experiencing severe mental health concerns, but healthcare workers are leaving the field at record rates because of this. If healthcare worker burnout isn't addressed, we are going to continue to lose folks from our healthcare spaces, especially in rural and traditionally underserved communities. And so do have a testifier to speak to this. I would just lastly say this is partially about supporting people who are doing this really difficult work, reducing stigma, making sure that they are aware of resources and getting access to care. But it's also a workforce issue because this is going to continue to cause people to leave these fields and cause more access issues for patients across Minnesota.
Thank you. And Dr. Chestovich, please state your name for the record and begin your testimony.
Thank you, Chair Wickland and members of the committee for hearing my testimony today. My name is Michelle Chestovich, and I'm a family physician here to testify on behalf of the MMA in support of Senate File 831. Rates of burnout are at an all-time high in medicine, and it is a real problem with real consequences. We need to support healthcare workers to address their own symptoms of burnout, or frankly, there won't be many of us left. National data rates show that early retirements and medical school dropouts and suicide amongst physicians and physicians in training are at an all-time high. The same survey shows that 80% of physicians agree that there remains a stigma around seeking mental health treatment. That is what this bill aims to address. Nearly 6 in 10 physicians have reported symptoms of burnout, including severe anger, tearfulness, or anxiety at work. 1/3 have felt hopeless and feel that they have no purpose. And more than half know a physician who have considered, attempted, or died by suicide. It is estimated that 1 million Americans lose their physician to suicide each year. These statistics are startling, but I want to share that they are also personal. My sister, Dr. Gretchen Butler, was a radiologist in the Twin Cities with a loving family, 3 young children, and a successful practice. She was admired by her patients and colleagues alike. She unexpectedly died by suicide on March 5th, 2021. As physicians, we are not always the best patients. We are trained to solve problems and take care of others. There remains a stigma in asking for help, particularly around mental health issues, and this must change. Many of these stories are about physicians, but similar reports exist for many other provider groups. If we continue to see rates of burnout increase, patients across the state will suffer because they can't see a doctor or a nurse or a pharmacist. Thank you for your consideration of this bill, and I'd be happy to help answer any questions.
Thank you for testifying and sharing your story. I'm very sorry for your loss.
Thank you.
Members, do you have questions or comments about the bill? Don't see any questions or comments. Thank you, Senator Boldon, for bringing this forward. It's certainly clear that there's a lot of work to be done to help people feel more connected to, resources that could help them. And we'll definitely, we'll keep your proposal in mind as we put together the budget. So Senate File 831 is laid over for possible inclusion. And members, we are at the end of our agenda, and this meeting is adjourned.